10 o'clock by my watch. I think that's 60 seconds behind, but we will make a start. So, good morning, everyone, and welcome. My name's Hilary Garrett, and I am a non-executive director at Cheshire and Merseyside Integrated Care Board, and today I'm chairing this joint committee of Cheshire and Merseyside and Lancashire and South Cumbria ICBs for the Shaping Care Together programme. Just for some formalities to start with, I've had no apologies from committee members. We are quorate, and there is no fire drill today. So if we do hear a fire drill, a noise, we go out the way we came in and congregate outside. First of all, before we get into the main part of the agenda, I just want to say thank you to all members of the public who've taken time today to travel here and to observe this meeting. Your interest and engagement so far in this important discussion and programme are greatly appreciated. I'd like to remind everybody that this is a meeting held in public, so it's not a public meeting. So members of the public, which are welcome, are asked to kindly observe the proceedings without interruption. I do recognise that the proposals being discussed today have generated strong interest and opinion. However, it's really important, actually it's essential, that the committee is able to conduct its business without interruption. If interruptions do occur, which I hope that they won't, I will have to adjourn the meeting to reconvene it without the public present. We are expecting actually to be at capacity today in the public gallery because we have had 100 people requesting to attend. So people may come in a bit late. We're also recording today's meeting, and it's also being live streamed via YouTube as well. So committee members, if and when you're speaking, please make sure you are close to the microphones in front of you. We have received and welcomed 20 questions in advance of today's meeting, so thank you to those in attendance who submitted them. We do aim to address the questions during the meeting, but if we don't manage to answer them all, just in relation to our time constraints, we will give a commitment to answer each question within 20 working days, and we'll publish the responses on our respective ICB websites. Just a reminder, this committee is a joint committee of the Shaping Care Together programme, and our focus is on the emergency and urgent care services for adults and children at Ormskirk and Southport hospitals. So, for today, the ask of this joint committee is to consider the decision-making business case, which we will hear about soon, then make a decision on the recommended way forward. Committee colleagues, you'll notice there's an addendum report from the Joint Health and Overview Scrutiny Committee. I have been made aware from the participants of this committee that it met last on the 6th of March, and it was agreed with the senior Democratic officers from Sefton and Lancashire County Council that this report will be provided to this committee as a follow-up report from that meeting. So, without further ado, I'll ask my colleagues if they can introduce themselves before we move into the main agenda items. Thank you very much. Debbie, if we start with you.
Thanks, Chair. I'm Debbie Corcoran. I'm Non-Executive Director with Lancashire South Cumbria ICB.
Just working. Yeah, good morning. I'm Rob Cooper, Chief Executive of Mersey and West Lancashire Trust and Senior Responsible Officer for the Shaping Care Together programme.
Morning everyone, I'm Halima Sadia, Programme Director for the Shaping Care Together programme.
Morning everybody, I'm Claire Watson. I'm the Executive Director of Health and Integrated Care Commissioning at Cheshire and Merseyside ICB.
Hello everybody, I'm Tracy Jess. I'm the Interim Place Director for Cheshire Merseyside ICB Sefton Place.
Good morning, I'm Sarah James. I'm the Integrated Place Lead for Central and West Lancashire on behalf of Lancashire and South Cumbria Integrated Care Board.
Hello everyone, I'm Andy Knox, Medical Director for the Lancashire and South Cumbria ICB.
Morning, I'm Frankie Morris. I'm the Associate Director of Finance for Cheshire and Mersey ICB.
Good morning everybody, I'm Craig Harris. I'm the Chief Commissioning Officer for Lancashire and South Cumbria ICB.
Thank you. Declarations of interest. The committee has a combined declaration of interest register, and that's been collated from each of the organisations' existing registers. So can colleagues confirm they're happy with the register, and if there are any additional declarations that need noting for today? Happy with that? Thank you. The minutes of last meeting. So colleagues, at the last meeting, can you confirm they're an accurate record of discussions and decisions, please? So those minutes are confirmed. Thank you. And I note there's no outstanding actions from the last meeting. So I'll now hand over to Rob Cooper, Halima Sadia and Craig Harris to take us through the decision-making business case. Thank you.
Okay, thank you. So just move through the presentation behind me as well. So this is the content of what we're going to go through today. So how we've arrived here, public consultation last year, our engagement with the Health Overview and Scrutiny Committees, consultation, feedback, impact assessments and further evidence, and finally the proposed recommended way forward and the opportunities that lie ahead. So how we've arrived here. As a quick reminder, Shaping Care Together programme, looking for long-term solutions to stabilise some of our fragile services and improve the care patients receive. It covers the area of Southport, Formby and West Lancashire, as you can see on the screen. So as you can see on this slide, it's been going on for some time, actually 27 years in fact. In December 2023, we relaunched the programme with a focus on urgent and emergency care, or UEC. We made the decision to start with UEC because getting things right here can help improve the flow of patients and service delivery across the wider hospital site. I'm pleased to say that since we relaunched, the programme has been moving at pace, and we've had to, due to the pressures that we are facing, and these pressures aren't easing up. In 2021, to help stabilise services at Southport and Ormskirk hospitals, St Helens and Nosey Trust formed a strong partnership with Southport and Ormskirk hospitals. In July 2023, the two became one as Mersey and West Lancashire Teaching Hospitals NHS Trust, and that helped a lot, with many services in a much better place than a few years ago. It's created opportunities and strengthened the configuration of services right across all sites. But what we're looking at now is how we can do even better in the future to create much more sustainable, safe, quality care which is needed for the long term. So the Shaping Care Together programme complements the 10-year plan, as well as the wider system urgent and emergency care plans and strategies. There is lots of great work that's already happening across UEC in both Cheshire and Merseyside and Lancashire and South Cumbria. And that includes the Lancashire and South Cumbria Integrated Urgent Care redesign, as well as the Cheshire and Merseyside Better at Home scheme in Sefton. So we've already outlined why change is needed, and these remain the key reasons that you'll see on the screen there. And I'll just run through them again as a quick reminder before we move on. So our population is getting older. That means more sickness and more patients with complex needs and rising demand for services. We're facing significant staffing challenges, like having too many unfilled vacancies for healthcare assistants and consultants, amongst others, resulting in reliance on bank and agency staff. And this isn't only more expensive, but it also makes it harder to build teams. It's becoming harder to maintain quality standards. Our last CQC report recognised that were some improvements made, but there's definitely more to do. Our finances are already stretched and no new funding is currently available to us. And lastly, many of our buildings were designed decades ago. Some need important maintenance work and others need investment to make sure they're right for us and to operate to modern healthcare standards. All of these pressures combined are putting a strain on our ability to provide the safe and excellent care that we aim for. So underpinning everything the programme does is our vision, as you can see on the screen there. Our vision is to find a way to organise services that make better use of NHS resources, to provide safe and excellent quality care that can serve us well into the future. And crucially, as you can see, any changes must be grounded in a model of care which ensures that our accident and emergency departments are available for everyone, all day, every day. And that's not where we are today, because as we know, 5 years ago, we had to close Ormskirk Paediatric Accident and Emergency Department between midnight and 8 a.m, and it's stayed that way since, which means we're not providing the model of paediatric acute care we set out to achieve, and that needs to change. And I'm going to hand over to Halima to talk through the process.
Thanks, Rob. So what have... Hang on. Need to click. So what have we done today? So in July 24, we set out why change is needed in our case for change. We then followed this with an intensive 10-week pre-consultation engagement programme, and then in winter 2024 we carried out a full and robust options appraisal process. During that same period, the two health overview and scrutiny committees of Sefton Council and Lancashire County Council agreed that this programme represents a substantial variation. And following that, we began drafting the pre-consultation business case and the consultation document. This was then approved by the Joint Committee of Lancashire and South Cumbria ICB and Cheshire and Merseyside ICB on the 4th of July. We then launched a full public consultation on the 4th of July, which ran for 13 weeks and closed on the 3rd of October. We then reviewed and considered the consultation feedback that was independently analysed, and later in the slides we'll share the themes and explain how we have approached the consideration of all feedback. And that brings us to now. We have developed and published the decision-making business case, and we seek the Joint Committee's decision on the way forward. And as Rob mentioned, this programme is about the long-term sustainability. It's not a quick fix, and it will take several years to fully implement. So in terms of ICB governance timelines, we had our first NHSE checkpoint stage 1 in June 2024, and this was approved. Then in July, both ICB boards signed off the case for change, and then by November 2024, each ICB board agreed the terms of reference for the Joint Committee and the delegated responsibilities. The first Joint Committee met in March 25, in private, where the proposals were endorsed. That same month, we successfully passed NHSE Stage 2 assurance checkpoint, and as I mentioned, in July, we put forward our consultation proposals, including the preferred option, to the Joint Committee, and that launched our consultation. Since then, we've independently analysed the information, as I said, and we've also had feedback from NHS England and the leads across equalities, estates, finance, communication and engagement, and all have confirmed they are satisfied with the DMBC. I'll now hand over to Rob.
Thank you. So, in terms of developing the list of options, we've had a really good response from pre-consultation engagement in 2024, with over 3,500 views and ideas analysed, and using these insights, we had 10 options which were reviewed and then evaluated. We then had an options review panel which included staff, patients and members of the public to assess which of the options met the agreed criteria and which should be taken forward to consultation. It is important to note that the programme team were not part of that review group or the scoring process to ensure the process was open and transparent as possible. Before we could move on to consultation, we drafted a pre-consultation business case, PCBC, outlining the whole process in detail and the evidence base underpinning the proposals. The programme team have been really thorough in making sure that all the available evidence has been taken into account when looking at the options, and that includes independent expert assessments such as quality, equality, travel and ambulance impact assessments. And I want to stress again how important it is for us to provide 24/7 emergency care, and we're not doing that now. As we mentioned, we had no overnight paediatric A&E for over 5 years, and that has to change. Our hospitals in Southport and Ormskirk are the only district general hospitals in England that arrange services with children's accident emergency on one site and adult accident and emergency on another site. The bringing services together is also supported by NHS guidance. Public, patients and staff showed widespread support for this when we asked for views during pre-consultation, engagement and consultation. So in terms of benefits, locating the children's unit on the same site as the adult unit can help improve how we deliver services. That will...
Can I just remind the public, this isn't a public meeting, it's a meeting held in public. So I ask that there are no comments made from members of the public and allow us to do our business accordingly. Thank you.
So, as I say, in terms of benefits, locating the children's unit on the same site as the adult unit can help improve how we deliver services that will benefit everyone. And on the screen are some of the clinical benefits and expected improvements from staff. So the two proposals we put forward in our consultation materials were co-location of a 24/7 adult and children's accident emergency on a single site, either at Ormskirk Hospital or Southport Hospital. Both options met the criteria set out by the programme. We also clearly identified a preferred option with the rationale explained in our consultation documentation and during consultation. Both options include additional parking, separate waiting areas, treatment rooms and entrances for children and adults, as well as keeping both accident and emergency departments open during any construction. So we've worked with clinicians from multiple specialties and providers across the area and used National NHS Clinical Senate guidance on which services must be co-located with an accident and emergency department. As shown on this slide, the Southport option would require less space because it would need one codependent service to move versus 7 services needed which aren't currently at Ormskirk. It will also take less time to implement, involve fewer staff relocations due to reduced service moves and cost less than the Ormskirk option. The options review panel scored the Southport option higher across all agreed categories. This is why the Southport option was proposed as the preferred option within our consultation. It is important to note that government and NHS guidance suggests that if you have a preferred option, that should be put forward in the consultation. The evidence I've outlined was also published in our consultation materials and presented at various events and public meetings during the consultation. This ensured people understood the reasoning behind our proposals and the preferred option and had the opportunity to provide feedback, suggest alternatives and challenge during the process. The consultation was not a vote or referendum. We have said this from the beginning. It wasn't about counting which option was preferred by respondents. It was about meaningful engagement to hear the views and ideas of people across the area. It is crucial to note that both Southport and Ormskirk hospitals will continue to operate now and in the future. The consultation was about where A&E services will be delivered from. We know, for instance, that Ormskirk is hugely important in the community, offering really good services like more than 200,000 outpatients per year, delivering 20% more outpatients than Southport per year and elective inpatients. Ormskirk delivers nearly 10 times elective inpatient activity per year than Southport, and that will continue. So we know that a proportion of people using accident emergency departments could be managed elsewhere, like 111, out of hours, GP, pharmacy first, etc. And you can see that our data supports this, with 40% of attendees going to Southport that could be seen elsewhere and 70% at Ormskirk that could be seen elsewhere in those alternative services that I've pointed out. I'll hand back over to Halima. Thank you.
Thanks, Rob. So as you know, I need to get used to that. As you know, we ran a full public consultation for a period of 13 weeks, again from the 4th of July to the 3rd of October. Our consultation was led by a comprehensive comms and engagement plan, so a communication and engagement plan, and it ensured it was informed by our equalities, quality, travel and integrated impact assessment. We also did a midpoint review to take a stock using feedback from consultees to assess what we needed to do differently or more of. So some of the feedback received was around putting in additional events in different areas, introducing collaborative forums for people to present their alternative ideas and evidence, and the introduction of telephone polling, which was implemented to reach out to the local population's underrepresented groups. We also used our engagement process advisory group, and this is made up of community and voluntary sector, Health Watch, members of patient groups and public to support us with reaching out to different communities. So what did our statistics say? So we reached out, overall, we reached out to over 7,800 people, 5,000 of which were our surveys completed. We did 14 public events. Rob will touch on the telephone polling, but we reached out to 507 people, and we did lots of other events, including 53 community outreach events, work that we did as well. On average, sorry, I just need to read this. So on average, the Consultation Institute says that we should, a 1% is considered a good response rate. And on average in the UK, the public response rate is around 0.7%. And for the population of Southport, Formby and West Lancashire, we reached out to approximately 3% of the local population during our consultation, which is really good. Over 2% responded to the survey alone. And when we compare to other NHS consultations across the country, you know, we fare relatively well comparatively. If I just go to the next slide. In order to ensure that there was sufficient information to give people intelligent consideration, the information provided to consultees was available in accessible and easily interpretable information. This was to ensure that consultees could provide informed responses through the formats outlined in this slide. So we made sure that the consultation documents were available in long form. We had easy read versions available. We had an animated video that was also available in BSL. Our public survey was also available in easy read, and we also had a much more detailed technical document by way of our pre-consultation business case. We also made any other formats available upon request. In terms of promoting the activity, we also did a lot of work around that, and like I said, we adapted our consultation during that 13-week process whilst listening to feedback to understand what needs to change and what more do we need to do of. So in terms of what those statistics look like, we reached out to over 270,000 people via digital marketing. So we had 28,000 visits to our programme website. We did a leaflet drop to over 110,000 addresses across Southport, Formby and West Lancashire. We also reached out to over 3,500 people via our stakeholder newsletter, and we also made a number of promotional materials available via staff drop-ins and our community outreach programme as well. And we also had about 60 pieces of media coverage as well.
I'm going to just remind people, kindly but firmly, this isn't a public meeting. It's a meeting held in public. We've had a 13-week consultation. I just want to be fair to everybody who's taken the effort. No comment or question. I'm going to give 10 minutes, 10 second silence so we could just all consider what this meeting is about. It's not a meeting for the public to give questions or comments. So I'm going to give 10 seconds silence, and then I'll make a decision whether to continue this meeting in public or whether to adjourn. But please, members of the public, just consider people have taken a lot of time and effort to be here, and I don't want to compromise people not being able to witness this committee. So I'm just going to give 10 seconds silence to let people decide what they want to do. And then I'll make that decision. Thank you. Just call it 10 minutes.
And the NHS and the council, how many are actually the public? I'm the public. Who else is the public? 4, 5? 5 of us who don't work for you. I'm really sorry, all of us work for them, but you can stop all of us. You work for them? Yes. You work for them? Yeah.
Okay. That's my final comment on the public commenting and asking questions. So, thank you, colleagues, if we could continue.
Thank you. So in terms of engagement with the HOSCs and the JOSCs, so as you can see from this slide, we have held regular meetings with both Health Overview and Scrutiny Committees. We had a successful joint Health Overview and Scrutiny Committee with Lancashire County Council and Sefton Council on the 20th of January, where the consultation process and insights were commended. We shared a full report in early February, and the You Said We Did report, which is our response to the consultation feedback and how it informs the DMBC, along with a briefing note outlining the direction of travel at the time. We also accommodated a site visit to Southport and Ormskirk Hospital, which we arranged for the 3rd of March. A further meeting was requested from the JOSC on the 23rd of February, which we arranged for the 6th of March to allow for sufficient time for the papers to be published. Throughout this process, the programme has worked openly and transparently with its partners to ensure scrutiny colleagues can engage with and review and discuss the consultation and its findings. The Joint Health Review and Scrutiny Committee also provided a formal response on the 11th of March, and we've also included that as a further addendum report as part of your packs today. This was agreed, as Hilary mentioned, with the senior democratic officers of the Joint Health Review and Scrutiny Committees. I'll now hand over to Rob.
Okay, thank you. So the findings show that geography appears as the single strongest determinant of preference. So those living near Southport and Formby overwhelmingly prefer the Southport option, and those living in West Lancashire, including Ormskirk and Skelmersdale, overwhelmingly prefer the Ormskirk option. And of course, the findings suggest this may be attributed to the consultation proposals put forward affecting certain areas and therefore influencing locally organised campaigns. And we also recognise that service changes can create apprehension for those likely to be affected, and that there has been clear and vocal opposition from some respondents. We noted the consultation findings in the independent consultation report that across nearly all questions the Ormskirk option is viewed more positively by the overall respondent population. It is important, however, to note that the number of respondents to the online and paper copy of the survey was not wholly proportionate to the size of the local population. As you can see on screen, responses from Southport residents were underrepresented, while Skelmersdale and Ormskirk were overrepresented, and this may be attributed to the consultation proposals put forward affecting certain areas and therefore influencing locally organised campaigns, as I said previously. So in terms of some of the findings from the qualitative analysis, it suggests that people are broadly concerned about a number of areas. Firstly, travel, access and transport. Of course, travel and transport to A&E is a major theme. For example, bus and road access came up a lot, as well as concerns around travel and impact on journeys across the areas of Southport, Formby and West Lancashire residents. Consultation process and trust came up. Some people raised concerns around the consultation process and whether the consultation itself will influence decisions. Parking and on-site access was raised. Parking came up quite a lot with people expressing views on difficulty in parking on both sites, queries around cost assumptions and people expecting any final decision to include additional parking, which is part of our proposals. Buildings, waiting environment and services designed around needs also came up. Respondents report overcrowded A&E spaces and want larger, well-designed areas with clear adult and child separation, accessibility features, wayfinding, basic amenities, quiet zones and real-time updates. Children's services and maternity neonates. We heard feedback from some people around impact on paediatric A&E, maternity and neonatal services and potential interconnectivities between these services, and some people felt these should have been included in analysis and cost of the proposals. And this is a good point to note that this current phase, this current phase of the Shaping Care Together programme, the Joint Committee are not being asked to take a decision on maternity and neonatal services, as these are out of scope. Separate to the Shaping Care Together programme, NHS England are leading a regional service review that is happening across the North West, looking at provision for neonates. There is also an NHS England regional and national review ongoing for maternity. Population demand and equity. The findings indicate that consultees raised queries around population profiles, housing growth, Edge Hill University students' population and tourist demand. And finally, staffing, training and workforce. Staff raised the impact on their own jobs and futures, travel issues, recruiting, retaining and training the right staff, car parking issues with sites and the interconnectivity between maternity services. All feedback has been considered, and Halima will explain how in a moment. All the detail is captured in Appendix 1 and 2 of the decision-making business case. So as you can see on the screen, we conducted an independent telephone polling exercise where more than 500 people were contacted, 10% of which were from BAME background to ensure representation, and these are the insights from that. And they found that for moving children's A&E from Ormskirk to Southport, support stood at 40%, while opposition stood at 38%. For moving adult A&E from Southport to Ormskirk, support stood at 35% and opposition at 45%. The 10-point gap shows that the people questioned were less comfortable with moving adult A&E from Southport than moving children's A&E to Southport. Mr. Halima, thank you.
What's been our approach to considering the consultation feedback? So we had a structured approach considering the feedback. The consultation feedback was reviewed independently, as Rob mentioned. All the feedback was reviewed by clinical and managerial leads across Mersey and West Lancashire Trust, the ICBs and partner organisations. We then applied a reassure, mitigate, change framework. And then we also set out a clear approach for assessing alternative proposals using a two-stage process that I'll describe in a moment. And as Rob mentioned, the framework was used to develop Appendix 1 and 2 of the decision-making business case. So as I said, the feedback was responded to using this framework where we either provided reassurance, offered mitigations where appropriate, and if there were genuine viable alternatives, then we would provide evidence of change. So, for instance, with respect to concerns about longer journeys, especially for Skelmersdale and rural communities, older people, disabled people and those without cars, the programme response has been to ensure urgent care services are being strengthened locally, such as UTCs, walk-in centres, 111 primary care, to reduce unnecessary A&E travel, and Craig Harris will touch on that more later. We've also designed and implemented a multi-agency travel advisory group to explore mitigations, for example, shuttle buses, public transport improvements. And another example with respect to the concerns about waiting area environments at Southport, the programme's response is that any future developments must meet NHS building standards with separate adult and children's areas, improved accessibility, wayfinding and amenities. In terms of that two-step approach that I talked about, so for any alternative proposals, we agreed to apply a two-step process. The first was to review whether the proposals was a variation or iteration of an option that had already been discounted. If it was a similar model, then a desktop review was completed, and if it was materially different to previously discounted options, it would undergo further evaluation. This was not required as no viable alternatives were put forward during consultation. If an option was completely novel, our process required it to undergo an evaluation, and during step 2, that evaluation process would have included applying the same hurdle criteria used during our original options appraisal process, and if it met the criteria, the feasibility review would then be undertaken. Like I said, this was, we didn't have to do step 2 as no viable alternatives were put forward. And again, the DMBC and the PACS details the alternative proposals and suggestions, which includes variations or iterations of options that were discounted and out of scope. So in terms of impact assessments and further evidence, we have updated our equalities, activity, quality, finance and integrated impact assessments, all refreshed to reflect the consultation feedback. All feedback meant no substantial change to initial modelling, and as I outlined earlier, no new viable alternatives emerged through the consultations, and concerns raised have been addressed through planned reassurance and mitigations. Throughout the consultation, public sector equality duty requirements have been at the forefront of our minds. A full and robust equalities and integrated impact assessment has been completed and published. It's within the pack of papers as Appendix 7. The findings show that there is an impact on older people, disabled people, unpaid carers, families with young people, pregnant women and low-income households facing transport poverty across both of the options put forward. Geography is the dominant driver of perceived impact and preference, and travel is the clearest mechanism through which unequal impacts are most likely to arise. The analysis also concludes that either option carries foreseeable risk of disproportionate impact, with moving services away from Southport Hospital having a greater impact of the two options, as outlined in Appendix 7. Mitigations have been developed and actions put in place to support implementation, and triggers for escalation and monitoring are also in place. All details, again, are available in the DMBC and the associated appendices.
So moving in terms of recommended way forward. So following full consideration of consultation feedback, updated modelling and clinical standards and equalities impacts, the recommended way forward is the co-location of adult and children's A&E services at Southport Hospital. This option remains the strongest clinically, operationally and financially, offering faster delivery, fewer service moves, less workforce impact and improved workforce sustainability and significantly lower capital costs. No new viable alternatives emerged through consultation, and concerns raised have been addressed through planned reassurance and mitigations. The recommended way forward will deliver a safer, more resilient, cost-effective and sustainable emergency care model for the future.
I do have to remind, please, members of the public, I do have to remind you, it's not a public meeting. Okay. I'm going to make a decision in the next 10 seconds whether to adjourn or to continue. We have to make an important decision today, this morning in the time allocated. Please. Continue, thank you.
So, some key points to note. We've always said that regardless of the decision, there's huge scope for opportunities across Southport, Formby and West Lancashire. The recommended way forward ensures that Ormskirk Hospital is not going anywhere. 86% of activity at Ormskirk Hospital is not related to accident and emergency services, and it's important to remember that. Huge clinical development opportunities to develop an elective hub, increase elective, day case and outpatient appointments at Ormskirk, increase diagnostics and opportunities to integrate with neighbourhood health services. Infrastructure investments, so endoscopy is currently located in the helipad building while its main unit inside the hospital is renovated to meet JAG accreditation standards. Once those renovations are complete, endoscopy will return and ophthalmology will also then move into the renovated helipad building.
Thank you. Okay, could you just finish your points, Rob, and I think we will adjourn because we can't continue, we can't concentrate with the comments that are coming from the members of the public. We'll just finish this section and then we'll adjourn and decide what to do. Thank you. Have you got any final points on this slide?
Yeah, I'll just, the last few points, thank you, Hilary. So, relocation of physio into completely refurbished accommodation, investment in fire prevention systems and electrical system upgrades, solar installations, EV charging infrastructure, securing purchase of properties now around the Ormskirk site to allow future development. There's a theatre refurbishment programme to start, and we have a plan against that, and refurbishment of clinical areas being used for administrative staff. And finally, it's also important to remember that 70% of patients presenting at Ormskirk Children's A&E could have been seen and treated elsewhere.
Okay. Thank you. Okay, so we're going to take 5 minutes to adjourn and we'll discuss how we are going to continue. Thank you very much. If committee members would like to come to the adjoining room, thank you. colleagues for your patience during that adjournment. It's really important, actually, that we get to the committee having a discussion and then making a decision on this important, what is a draft decision-making business case. And we hope to do that in public. This is our final attempt to do that. So any more interruptions, and I will have to adjourn, and we will have to discuss, continue this discussion, and most importantly, the decision in private. So I ask you kindly but firmly to allow us to do that without any interruptions. Thank you very much. Craig, I think you had the final slide in this.
Thank you, Chair.
Yeah, great.
Again, Craig Harris, I'm from Lancashire and South Cumbria ICB, and as you can see, this is about the opportunities to improve care in West Lancashire. And I just wanted to reaffirm our commitment to the provision of urgent and emergency care within West Lancashire. We want to make sure that all of our residents can get access and be supported as locally as possible. So when they do need specialist emergency care, they get it, but also we can support them in their community. So that includes a range of services such as NHS 111 for advice and guidance. That's 24 hours a day, 7 days a week. We've put more appointments in primary care, and through our extended hours, we've got more GP appointments now available, 8 a.m. till 6 p.m. And we have 19 community pharmacies offering services for advice and guidance and treatment across the borough as well. We've also committed to the continuation of our urgent treatment centre in Ormskirk and the walk-in centre in Skelmersdale. And we're in the process of procuring a new contract for that service to ensure that it stays in place. You heard Rob mention earlier that 70% of those attendances at Ormskirk could potentially be seen elsewhere, and we want to ensure that we've got provisions within our community to do that. We need to take the opportunity, depending on the decision today, to see what other services we can consider in relation to the future to ensure it's fit for purpose. So in relation to some of our urgent treatment centres, we need to see whether or not, for example, we need additional paediatric nursing skills. And that's something we will commit to do as a part of any implementation plan if that decision is made. Alongside this, we heard concerns about investing in our highest need areas, of which Skelmersdale is one of them. So we've committed to good quality estate, and we've committed to build a new £4.4 million health centre in the heart of Digmore. We will work with our communities and wider stakeholders, and this is to complement and supplement the 20 million investment for Pride in Place. Really important that we obviously get the right estate for our population. We also want to make sure, in addition to that, we've got provision targeted to particular areas. So we've put additional £178,000 investment in for primary care this year to do targeted reaching out proactively to individuals within the community, and that's to help those with the greatest health inequalities. Finally, our residents have told us that they want as much care as close as home to possible and provided in a joined-up way that's integrated. We're going to work with our primary care networks, our GP Federation, our partners, and we're going to ensure that that neighbourhood health model across the 3 localities in Skelmersdale, Ormskirk and the villages of the northern parishes is a priority for the ICB. Thank you.
Thank you, Craig. Anything further, Rob?
Yeah, just a couple of slides left, and this is in relation to the implementation plan, and it's vital to note that changes aren't going to happen immediately, and I've talked about that before. It's estimated that delivering the recommended way forward could take a minimum of 3 years, allowing the time needed to plan safely, invest appropriately, and work through the practical implications. So throughout the period, we remain fully committed to working closely with our staff, patients and local communities to ensure everyone is actively involved, kept informed and able to shape how these changes are developed and introduced. Our priority remains the delivery of safe, sustainable and high quality urgent and emergency care for the populations we serve. So the ask of the board today: we want you to consider the decision-making business case and subsequently make a decision on the recommended way forward. Thank you.
Thank you, and thank you, Halima and Craig, obviously Rob, for that is very detailed, thorough presentation. So now open to questions and discussions from the committee members.
Thanks, Chair. Okay, so from my perspective, having reviewed all of the reports and the paperwork, you've clearly set out the context really helpfully, and also the process and the how and the why that's led you to make the recommendation today. So there's some areas that I'd like to test really that are very important in terms of the decision being taken today and it being robust and evidenced. So I'll start with one, and then obviously I have others, but we'll obviously open the floor. So the first one that I wanted to start with is to focus in on the engagement that's happened and the consultation. So the slides have set out really clearly what the process was. You've shared with us the independent assurance. Obviously the statistic that the response rate has been far higher in this consultation is really positive. But I did note when I went through the papers that there was an independent midpoint review that identified there were some challenges with promotional activity in certain geographic areas and the importance of representation of some demographic groups in particular, given the significance of the changes in the local communities that would be affected. So there's two things really. I'd like to explore how satisfied you are and what assurance you can give us that everybody in the communities has had a fair opportunity to participate, because that's obviously critically important. And then linked to that, I'd like to just explore if you can share some specific examples about what you've heard through the consultation and how that's actually changed the recommendations today and the mitigations, just to test the golden thread really that's run through. Okay, thank you.
Yep. So in terms of the consultation and the midpoint review that we did, what we noticed and what those challenges were came from a number of councillors around some areas like Burscough and Skelmersdale, and making sure that there was some additional events there. So we did introduce some more drop-in sessions, so in Burscough and Skelmersdale, to address those issues, just to make sure that that reach was there. And in terms of the consultation and how some of the feedback that we've received from residents, how that has influenced the decision-making business case. I think we can acknowledge that the themes raised by West Lancashire have set, what we've done with the DMBC is we've set out more clearly around things that we are going to do, particularly around West Lancashire, and I think Craig has touched on that, so that's really outlined and a lot more robust in our decision-making business case, particularly in our appendices, but also detailed in the documentation as well, and some of those commitments that Craig has made is outlined within the documentation to support that. So that's one of the key things that we have taken away and that we have implemented during our consultation feedback. I don't know if Rob or Craig want to add, or Sarah want to add anything on to that.
Any more questions? Comments? Can I ask, was there sufficient primary care services engagement in the consultation and the design phase from the West Lancashire community, and how do we ensure their continued engagement as we move forward?
So throughout the consultations, the PCBC outlines the engagement with general practice. So we've done that through our bulletins, and we've gone out to the GP forums, both in West Lancashire and Sefton, just to make sure that they're fully engaged, both in the design phase, so they've been supporting as part of the process to influence the PCBC. I think there's more work that we can do, and then we will continue to do during implementation, and we've made that commitment both in the PCBC and in the DMBC as well.
And are there any emerging concerns, excuse me, emerging concerns from our primary care colleagues around the future of more neighbourhood services?
Might just be helpful if we talk about some of the primary care neighbourhood services in Cheshire and Merseyside. I'll hand over.
Yes, thank you very much. So just to answer your question in terms of the Cheshire Merseyside GPs, they have been engaged with the process in Sefton. We have done that through our wider forum, through our bulletins, and through significant leadership from our clinical director for Sefton Place. And I suppose to pick up on the neighbourhood health work, we're a pioneer neighbourhood health pioneer in Sefton, and that means that we've been trying to accelerate a lot of the work we've done around neighbourhood health, and GPs are at the forefront of that work in terms of driving some of those developments. So just to assure you that has happened from a Cheshire Merseyside Sefton perspective as well.
Thanks, and Craig and Sarah, thank you.
Thank you. I'll pick up the same from a Lancashire and South Cumbria and specifically West Lancashire perspective. So, yes, absolutely. Our primary care colleagues were engaged with our West Lancashire GP leadership group, and through our clinical lead, Dr. Lizzie McPhee, who's been part of this and taken part in bringing the information to and from our GP colleagues. They've also formed part of the urgent emergency care clinical subgroup that sat alongside the process as we've gone through as well. And similar to Cheshire Merseyside, we are also developing our approach around neighbourhood health, which I think it's important to note will be one of those things that will help to care for people at home, closer to home. Those 70% of residents that we hear using that accident emergency department at the moment that could be treated elsewhere can be supported through our neighbourhood health approach, working with our GP colleagues.
Debbie?
Thanks, Chair. So the next question's around transport and mitigations, because again, that's something that's come through as a really strong point of feedback through the consultation and through the engagement. So could somebody give me some more assurance around sort of how transport will be considered and the mitigations that are in place against it? I'm very conscious the research itself showed that there's a risk that the service change could impact on older people, disabled patients, low-income households and families with young children who might have to travel. So it is particularly important in terms of the decision. We've got some assurance around that, of how that would work and be mitigated.
I'll start, and I'm sure if Rob and colleagues might come in. So in terms of travel, we mentioned the travel advisory group that we've got set up, and that is made up of Lancashire County Council, Sefton Council, the Combined Authority, and a number of other partners from Mersey West Lancashire Trust, as well as both ICBs as well. And that's looking at exploring some of the feedback that we've received. Now, I think what we need to recognise is some of the transport issues that were highlighted aren't within the remit of health to resolve. But what we do want to do is find some of those strategic solutions with our partners to support our patients and public with accessing healthcare as and when needed. And some of the solutions that we will be exploring, as I mentioned earlier, will be shuttle bus services, as well as any other solutions that we can work up with our partners as well. So that commitment's there. It is part of our governance, the Travel Advisory Group, and it will feed upwards through the process as well. I don't know, Rob, if you want to add anything further.
I suppose the only other point that I would add is that we've talked quite a lot, haven't we, about providing services locally. There's commitment from both ICBs that they provide urgent care local to the community, so with the neighbourhood health and also the integrated urgent care work that's ongoing. So wherever possible, we need to mitigate the need to travel to other organisations, other hospitals that are outside of the community. Of course, then we need to focus on where emergency transport is required, that they get there in the safest, quickest possible way. So we're working with the North West Ambulance Service as well to ensure that we're getting the right people to the right place. So therefore, retaining the services from an emergency perspective for the people who need it, and then providing local services so people don't have to travel in the first place.
Apologies, I have got more.
Go for it, Debbie, you go for it.
That's what we're here for. So I wanted to ask next about the feedback from staff. So obviously it was a really important part of the consultation to get staff voice and to hear from staff what the views were around the changes. And you've shared with us some information around workforce planning. So I just wanted to understand sort of how that workforce transition plan would be developed and how it would work in terms of staff consultation if we approve the recommended way forward. And can you give us any assurances around if there's changes around workforce numbers through this change process, how that would be A, recognised really quickly, and B, dealt with so that there's no impact in terms of patient safety or access?
Yeah. So to some degree, this needs to follow the decision. So obviously we're waiting for the decision of which area that the services would be co-located. But as with any service change that involves staff, there is always full consultation. So we need to be able to speak to staff about those changes. I think we need to also acknowledge the fact that change isn't immediate, and actually it's going to take a number of years to be able to create the space to actually move the services. And over that period, a full business case will be produced on the back of the decision, and that will include implementation plans that will include workforce implications as well. I think it's probably worth noting as well, as we said during the presentation, that there is quite an over-reliance on agency and bank staff. So actually what the co-location on either site brings is a better use of the staffing resource, better team building, working together, much better use of resources, as I've already said. So from that perspective, I think the byproducts of all of that is that there will also be efficiencies from a financial perspective, because we're not then paying for premium cost staff to fill gaps. So staff will absolutely be engaged all the way through this process, and we're going to do that immediately. So I'm going to speak to staff this afternoon pending whatever happens today, and then we'll continue to do that on a regular weekly basis as we move through this.
Good, that's great.
Sorry, two more. So now moving on to the money and those aspects. So I wanted to probe a bit around the capital cost for the Southport option, because you've given us some estimated costs with the risk allowances, which are obviously really important. Just want to test what proportion of the funding's already secured, because obviously there's no point making a decision if the building that's expected and the investment that's needed couldn't happen. So are there assurances around that? And are there any risks that you can see that might impact in terms of that happening? I think the related point as well is I'm conscious, because it's a complex decision, isn't it, where we've got two ICBs involved, and the capital budget, I think, is held by Cheshire and Warrington ICB. So it's just understanding how that would work as well, so that there's assurance. Would the money be ring-fenced? Is it built into your planning? I just want to test that really, because it's so important to what's decided and how it moves forward.
Okay, I'll start on this one. If other people want to comment, please do. I talked in the presentation about Mersey and West Lancashire Trust coming together as an organisation in 2023. The purpose of that was to then support Southport and Ormskirk and improve the level of fragility that we saw within a number of the services. And as part of that transaction, we agreed that there would need to be a level of capital that was put aside to be able to make such changes across Southport and Ormskirk hospital sites. So there is a percentage of the capital that's required, whether each option would be able to contribute towards that. And then, as we've agreed at each stage of this process, both with the regional team and through to national team, that it will then follow that process that will go through to region and through to national funding streams. We also know that over the next few years, there has been some money put forward for integration and also improvement around urgent care and other services, and we've taken the opportunity to bid against that as well, to see if there's some capital that we can draw down from that money, which is solely for improving urgent care services across the population.
And if I come in, then I'll probably pass to Frankie, who, in terms of the finance. So we've been clear from day one in this that we would need national funding, capital funding to support that. So we've been clear as an ICB, and Lancashire and South Cumbria have as well through the programme board. But as Rob said, that the Trust have put aside some funding. We've got the 4-year allocation that's just come down. We've just put our submission in about 2 or 3 weeks ago. And I think we are looking for additional funding as well. So it's not just the Trust, though. I think all of this is about sort of integrated pathways and integrated working. So in terms of improved community services, in terms of primary care, in terms of strategic primary care and urgent care, this is about an end-to-end sort of whole system approach to urgent care that we're supporting with this business case. But I'll just hand to Frankie for a bit more detail on capital.
Thank you. Yes, just wanted to add that there's sort of two sources. There's money put aside, which we're absolutely supportive of, and that was part of the merger agreement a few years ago, and the national application that we put in we're fully supportive of, and that is going through the process to access national funds, which is key to this. But yeah, there's that fund is available for this, so it's about us supporting that application process.
Thanks, Frankie. have you got another question, Debbie? Good, good.
Yeah, so I wanted to focus on the sort of implementation and ongoing assurance, because obviously it's a critically important decision today that stretches into the future. So I'd really welcome some kind of understanding over sequencing. So what will be the sequencing of any decision sort of after today? How will the assurance be built in, and how will we keep an eye on what happens in terms of the provisions so that there's not risks that we miss? Because it's a long lead up to change, but once people know that there's a decision, it affects people's behaviour, doesn't it? And it could lead to risks.
Yep, so we have the Shaping Care Together programme board, which is made up of executives from Lancashire and South Cumbria, Cheshire, Merseyside, and Mersey West Lancashire Trust as well. So we will continue with that, and we will feed upwards through the appropriate routes, but we will also use existing structures as well, built in Lancashire and South Cumbria and Cheshire and Merseyside ICB, to make sure that we're reporting inwardly. So I think that we can make that commitment. Rob, I don't know if you want to add on to that.
I suppose the only other thing that I would add is, and this has come up a couple of times, particularly from some of the councillors within West Lancashire, is that we probably need to strengthen the information that comes through the organisation through to oversight and scrutiny, and we've committed to that. So we're working with Lancs and South Cumbria, and particularly with Sarah in West Lancashire, to make sure that that happens, so we can provide the assurance that during this time there's further information that is passing through then to provide the assurance with current process, but also follows any changes that we commit to.
I think it's just also worth saying that NHS England sit on the programme board, and I think that's important in terms of the flow of business right through to, I mean, we've talked about capital, national funding for capital, and the approval for the business case, so I think it's important that we note that, because that's part of our assurance for sort of continuity.
So there's one thing that continues, if I may. Yeah, I'm just sort of picking up on that point and the assurance. How does that connect in, Craig? You know, with the slide that you've shared today about the changes around commissioning that our ICB would make to strengthen delivery of services within the community. Can you give us a little bit more detail in terms of how that might flex or change, or how it would be approached?
Yeah, so there's multi-layers, not to bore everybody, of governance within the ICB that would report directly to our board for oversight. So through our urgent and emergency care boards, we will be looking at the developments and any additional support for the urgent and emergency care pathways, particularly for West Lancashire. That would link as well to our newly formed strategic commissioning committee, which should have oversight of the full deployment of resources, so how the primary care subcommittee would feed in, and we would have line of sight. A AAA report therefore then goes to board. So through Shaping Care Together programme board that I sit on, linking with our assurance committees and our delivery boards, that's how we triangulate, looking at all of the either additional income or investment that's going in, but also the delivery element to ensure that West Lancs population gets the best outcomes with any changes that we make.
Thank you.
Great questions. Any more questions before I make a comment? Claire?
It's not a question. I think it's just for assurance in terms of Cheshire Merseyside governance. We have similar processes. Obviously, our urgent and emergency care board. We're just going to be developing a single improvement plan oversight board. I've got a strategic commissioning programme board which will report into that. So we're reviewing governance at the moment in Cheshire Merseyside, but can assure the committee that we will have the right sort of assurance and sort of regulations to make sure this fits very much within our sort of overall approach, and it is, you know, it sits within our strategic commissioning plan as well.
Thank you. So that's governance, oversight and strategic fit, which is great. We do need to get to make a decision, but before that, I just want to commend Selena, Rob and all your team around your consultation. I think it's been cited by both ICBs and regionally as best in class for the NHS in terms of methodology, reach and scope. So thank you for that. And also the fact that you've built in, you know, some of that feedback into the mitigations. So thank you for that. So we do need to make a decision, and I'll go back to the recommendations. So after fully considering the decision-making business case, we do need to make a decision, please, let us do that. After considering the decision-making business case, particularly, you know, we've heard views and evidence from the public consultation, the clinical evidence, the information about inequalities and other impact assessments. We've talked about workforce sustainability and activity, modelling, and other practical considerations. And we've also heard about, you know, the opportunities to improve care in West Lancs, so what we're gaining, not losing, and the governance and oversight for any work that will be taken forward. So the ask of the committee is to approve the relocation of paediatric A&E from Ormskirk to Southport, to extend this to a 24-hour service co-located with 24-hour adult A&E. Can the committee approve that? Thank you for that. I'd like to thank my colleagues for steering this, well, overseeing the programme, and to members of the public who've attended today, and particularly for those that have been involved in the consultation so far. So I'd like to draw this meeting to a close. Thank you very much.